Thank you so much. At the outset, I would like to place on record my sincere gratitude to Gaurav and Saura and the entire team of Drishti for this beautiful organization of this wonderful meet on glaucoma. मैं अपना ये talk Indian Armed Forces को dedicate करता हूँ for the Operation Sindoor. That what we have shown that हमारी जो सेना है वो काफ़ी सशक्त और बलशाली है and it can put anybody to fear, and we are a force to reckon with. With that, I start my talk that interventional glaucoma, a mindset change in the glaucoma management. I don't have any financial interest. So we know how the journey of glaucoma from historical concept to paradigm shift in the treatment, the mixed overview, the KDB deep dive and the iStent technology. So this is the normal what we have been seeing, the legacy of paradigm of treatment, that medications, you keep on adding medication, 1 medication, 2 medication, 3 medication, and then you do laser, then do filtration surgery and additional filtration surgeries. So this mindset has to change now. You see, we all know that the first drug which is started gives you the maximum effect on the IOP, and then addition of further drugs, the response is not that much as compared to the first drug. This was a study which was done in 2006, where the IOP fluctuations in pre and post SLT laser and as compared to the surgical intervention. We see that SLT laser gives the maximum pressure control in the nocturnal IOP, and whereas the surgical intervention gave the best control over the IOP fluctuations. So this is what is the control. If you see this, the surgical patients perform much better as compared to the laser patients. So we know that why should we shift these patients away from the number of drops that we have seen. These patients, they come back with a lot of vengeance, the hyperemia, the allergic reaction, the ocular surface disorders, patient coming with dry eyes over a period of time, and this leads, and the further surgeries, you are planning a surgery because of the cicatrization, the results of the surgical intervention is not as good as it should be done. So now the new paradigm, what we see is shifting is that we have been advocating that SLT can be a first line of treatment. In fact, the patient comes to you, you know that patient is not going to come back for a follow-up. We have seen patients landing up, even we have seen ophthalmologists also landing up in advanced glaucoma. So SLT, then you can start a drug, but do not wait for the drug, 1 drug or 2 drug to take an action. Mix should be considered early, and in that, suppose it doesn't work, then you can do other forms of surgeries, minimally invasive bleb surgery, and the filtration surgery is, of course, reserved for cases where you don't achieve that optimum results. So what is mix is, we know that it's a micro-incisional, minimally invasive, targeted approach. We either focus on the trabecular meshwork or we do the bypass. The safety part we have seen, I have not seen any complication in the mixed surgery. The surgical results are very good. And the surgical time is, we all know that it doesn't take more than 2 to 3 minutes of a surgery in the mix. And recovery is, of course, very fast. So these are the options available in mix, that you have a trabecular bypass like eye stents, trabecular ablation like the laser SLT, goniotomy like KDB, and of course suprachoroidal shunts like CyPass and Zen, which takes away and uses the alternate pathway. So the iStent is also, see, anything which is successful will have the newer model coming up. So iStent also faced that upgradation of model from iStent to now to iStent W. W is for wide, the base is wide. Then of course Hydrus microstent and KDB glide. So this is how a KDB glide, it's a proprietary item, it's a beautiful piece of glide. It facilitates, it just lifts the trabecular meshwork and cuts it very cleanly. So the advantage of this over other surgeries like bang is that there are no leaflets of trabecular meshwork, And we all know that these fine leaflets are what is over a period of time will cause fibrosis to happen. And this is what is avoided because the cut is very clean, and the proprietary heel or the blade, the heel of the blade sits snugly over the Schlemm's glass, and you can easily, beautifully glide because the edges are parallel and creates a beautiful fine cut. This is how stent looks. It's a 360. It's a 360 micron stent. A double. There are two stents in one injector, and there's a head, thorax, and the white flange. This is what we have started doing. That we've been actually, doing all these surgeries blindly. We just know that the nasal collector channels are the highest and the temporal is low. So we have been just doing just do in a nasal quadrant. But there has to be some rationale behind this. So we have started with getting this aqueous angiography. We have started doing this aqueous angiography pre and post mix. So this is how, if you see this, this is the left hand side is the nasal quadrant, and if you see this collector's channel, you inject. You have to first you have to inject ICG. ICG will visualize this. You can see this. The collector's channels are getting. You can see this. On the nasal side, you can see the good collector's channel. ICG, one word of caution that it is little endothelial toxic substance, so you may see little amount of corneal edema in next 2 to 3 days, and that is what. But the trabecular mesh work is stained beautifully with this ICG. So this is, once you've done the ICG, you've done your surgery, and then last phase is that you do an FFA. You put fluorescent angiography, and you see this. This is post eye stent. This is very important. If you see this, we put 2 stents. You can see this stent. One part, the flow increased. The other stent, there was no increase in the flow. If you do without this, what we saw, normally we saw both the stents were well placed and there was a gush of blood. So normally you say that no, I've placed in a, it's going to work. It doesn't work like that. So we have a research project which is going on. In fact, Dr. Tanuj is also there with us. He's also going to share data with us. So we are going to do this study mix in both high flow and low flow areas to see how effective it is going to be. It is not necessary to address only the low flow areas. We can also address the high flow areas. Again, this patient who did not, that one stent did not work, we are going to repeat this angiography after a month to see whether does it open up after a month or is going to remain like that. And these patients are going to be monitored for next 6 months over the IOP control. This is how I told you this, it increased there and there was no increase in the other part. This is, I'm sorry, but this was a video which was recorded in 3D. I was told that we will have, everybody will have their 3D glass and they will be able to watch this 3D video. So this is how we did the eye stent. Since it was the first 3D video, getting the hand was, the tactile sensation, everything was little different. So this is how ICG it looks like. See this? So there also one of the stent came out. So just rethreaded it, put it in a separate. Don't, if you have a loose stent in one part, do it little away from there, because if you put it again, it's again going to come out. So this is how you see the trabecular meshwork. It's beautifully stained with the green. This is because of the ICG, and you can see the blood egress from one of the stents. Again, the same thing, blood was oozing out from the other stent, but it did not produce the result when we did the angiography. So this was, the second stent was loose, so we took it out, rethreaded it, and see this taken it out. There's a blurring because of it's a 3D video and we are not watching on a 3D set. So this was again a 3D microscope, but without, this is a 2D video. This is what we did with this is a KDB. This after doing a phaco, you I'll just come to the the thing is that once the pupil starts, this patient was on a prostate medicine, the pupil starts constricting, and you have a plate of cortical matter, and the patient is slated for a toric lens. So you can't even dilate the patient because you can't put any adenine because you don't want to have a dilated pupil. So you do this, remove everything. This was recorded on the C-Luma, which is a Bausch & Lomb 3D microscope. They put it as we were the first center. They put it in the country in South Asia, and we use this. The good microscope. They have a very good this thing that you there's a button. You just press it, and you don't have to manually tilt it. It tilts it on its own. And this the other microscope what we have Zeiss RTO 850, again the same thing, just a button, and it doesn't have to be manually tilted. So this is my technique of doing the KDB. You put a mark in the center, just go inside out on both the side and take out a good strip of trabecular meshwork. We have started sending those trabecular meshwork for the sample also, that actually what we are touching out and the morphology of this trabecular meshwork. So this is the we have we have given the research project of RCT on efficacy of KDB, goniotomy assisted mix, versus eye stent in open angle glaucoma in Indian eyes. This is the number of eye stents we have used around. In 1 year we have used 134 eye stents and 91 KDB glides, and if you see, the results are comparable. This is, we know the mechanism between these two, and what I told is the result. So what advantage is of KDB is over eye stent is that it's a cheaper. You can use we have started doing in angle closure glaucoma also. So this can be done, but the stents cannot be used in angle closure glaucoma. It can be done as a standalone case or even in phakic eyes. We have done a lot of cases in phakic eyes as a primary standalone procedures. So this is the other research project which we are doing about checking the aqueous angiography in pre and post mix using aqueous angiography in high flow and low flow regions. We know these are the various limitations. We are waiting for the long-term data. Will come out in next 6 months. We'll come out with more data and present, and it offers a very safe early surgical options. Economically, yes, initially it may appear that it's costly, but over long run it will be cheaper in all those patients without any side effects of the drops. So it is what I say is that embracing a proactive mindset to preserve vision and liberate the patient from burden of daily medications, and future will be interventional glaucoma. Let's keep opening the new angles in glaucoma care. Thank you so much.